So, hello everyone and welcome, and thank you so much for joining today's conference. This is the conference for the Turkish Academy of Aesthetic Dentistry. I'd like to thank you all for attending today's lectures. I know we have a great lineup of international speakers that have great topics to speak about today. Today is a day that is full of knowledge and full of information, and I would encourage you all to stay for the full duration of the conference. I think there's a lot of information that we can learn from today. With this in mind, my name is Dr. Sam Omar, and today's topic for me is going to be maximizing efficiency through digital planning with R2Gate. Again, my name is Dr. Sam Omar, and this is just a few information about myself. I'm a general dentist with a private practice in Cairo, Egypt. I'm also a resident in the prosthetics department, Cairo University, also a member of the R2 Digital Development and Education team, an R2 Gate and an R2 Digital Oral Design trainer, and an international lecturer and speaker on digital implantology, and an active member of the Digital Dentistry Society, DDS. With this in mind, let me just go ahead and start to talk about our topic today. Our topic, we're going to include a lot of content. We'll talk about a few bits of information about R2Gate. We'll talk about data collection for digital planning. We'll talk about the 5 dimensions of treatment planning. We'll also talk about how to reduce chair time and increase our efficiency. We'll also talk about the one-day implants concept, smart digital tools for maximum efficiency. So this is basically our content today. And let me start by saying this. In the past 50 years, in the past 5 decades, most of the advances that happened in dentistry were actually for the sole purpose of 3 things. Number 1, reducing time. Number 2, reducing cost. And number 3 is increasing the quality. And this is all in turn will lead to an increase in profitability because this was the main focus for the past 5 decades. On the other hand, with what we have right now and with the global pandemic and these global crises that we went through the past few months, all the priorities have completely shifted, except for one, which is reducing time. Time will always be the most valuable asset, and what we'll always try to do is we'll try to find ways to reduce time. And that's number 1. Number 2 is one of the most important things right now will be reducing risk. We're trying to do our procedures with the least amount of risk for us and for our patients, and we're trying to increase the efficiency for us and also for our staff and also for their patients. And this all in turn leads to an increase in efficiency, and now you'll find that now priorities have shifted. So we've shifted from being focused on productivity and profitability to focusing on efficiency, and efficiency is actually our key word here today. Okay, well, how can we be more efficient in implantology? So today we're going to be talking about digital planning, guided surgery, immediate provisionalization, digital devices like ISQ, and smart digital tools like the scan healing abutments. So let's talk about efficiency. In order for us to be efficient, we have to make sure that we're efficient in every part of our treatment. That includes planning, executing our planning, and also the follow-up on our treatment plan. So let's talk about efficiency in planning. That's the first part that I'll talk about in my presentation today. How can we be more efficient in planning? Let's talk about guided surgery softwares and planning softwares in general. My main focus today is going to be about R2Gate software. R2Gate software is a software that allows you to treatment plan your implant case or treatment plan any case for that matter. And what you need from R2Gate is to get this particular information. You always need that input. You need the CBCT scan and you need a model scan for you to start to do your treatment plan. Now that we gather this information, we start to do our treatment plan. And we always plan based number 1 on the restorative position because remember, patients want teeth and not implants. And number 2, we plan based on the availability of bone and soft tissue as well. So let's talk about restoratively driven planning and how we do the top-down treatment planning using the R2Gate software. So we said at the beginning that we always get a CBCT. We get the model of the patient, we merge all the data together, And then before I start to treatment plan my implant, I always need to plan my prosthetic first. After I treatment plan my prosthetic, then the last step will be to treatment plan the implant, and this is what we call the top-down treatment planning or restoratively driven planning. And the reason why we do this is because we want to avoid having any prosthetic complications through the planning before we place the implants. The second thing that we plan based on is availability of bone and soft tissues. In order for us to also place our implants, we need to make sure that we plan our implants in the best position in bone and in relationship to the soft tissue. And that's why we made the 5 dimensions of treatment planning. So I've been planning implant cases for almost 5 years now. And what I learned was we need to make sure that we have a blueprint for us that would help us with planning, and those criteria will basically help us place implants in the best prosthetic position and the best biological position altogether. So what are the 5 dimensions of treatment planning? So when we're placing the implant, we need to look at the implant. When we're positioning it in the treatment planning software, we need to look at it from a buccolingual position. That's the dimension number 1. Dimension number 2 is mesiodistal. Dimension number 3 will be apico-occlusal, relationship to important anatomical structures, bone level, running room, and native bone engagement. Dimension number 4 is relationship to the adjacent teeth, implants, wax up, and AP spread. Dimension number 5, which is bone density and loading. And right now, we'll go through all the 5 dimensions of treatment planning one by one. So dimension number 1, which is buccolingual. When I'm positioning my implant in the treatment planning software, I need to make sure that I look at the implant from a buccolingual perspective. So what am I looking at and what am I doing when I'm doing that? Number 1, I need to make sure that we have at least 1.5 to 2 millimeters of bone on the buccal of the implants, or 1.8 according to Spray. And the reason why we do this is because the bone that we have on the buccal side is usually what we call cortical bone. This cortical bone has low metabolic turnover rate. What does that mean? It means that this type of bone, the capacity of it to repair itself or to sustain itself is actually very low. So what we need to do is we need to keep that bone in a certain thickness where that bone will be always viable. And we need to do this is because we want to preserve the bone that we have on the buccal side, and we want to prevent long-term dehiscence of the labial bone of the implants and the subsequent show through of the implants. Number 2 is mesiodistal position. So what do we look at when we're looking at the implant from a mesiodistal dimension? Number 1, we look at the implant and we make sure that we have at least 1.5 millimeters of bone from the lamina dura of the adjacent teeth to the surface of the implant, just to make sure that we avoid injury to the adjacent teeth. Number 2 is we need to make sure that we have at least 3 millimeters between our implants, not to lose the papilla and not to end up with black triangles like what we have on the lower right side here. Dimension number 3, which is apico-occlusal. So what do we look at when we're positioning the implant in an apico-coronal position? So we need to keep one thing in mind, which is basically running room. So what is running room? Running room is the distance between the implant platform and the zenith of the soft tissue. So this distance right here is basically what we call the running room. And we need to make sure that this distance is at least 3 to 4 millimeters. And the reason why we do this is we want to make sure that we have enough space for the biological width of the implant. And we need to make sure that we have enough space for us to transition from the circular diameter of the implant to the final diameter of the tooth, which is usually not circular. So we need a certain amount of space, and this amount of space is 3 to 4 millimeters for us to end up with what we call an anatomic emergence profile or a good emergence profile, and that will help us preserve the bone level and preserve the soft tissue around our implants. So always keep that number in mind, 3 to 4 millimeters from the platform of the implant to the zenith of the soft tissue. Very good. Dimension number 3, also we have native bone engagement. So what do we exactly mean by native bone engagement? Well, this is basically a rule that we need to apply mostly in extraction sockets or in cases where we're planning the implant very close to the sinus. So what that is how much bone are we engaging when we're planning our implant? Because we want to make sure that when we're placing our implant, we get adequate primary stability. So the rule is we need to make sure that we engage at least 4 millimeters for primary stability of the implant, or for good primary stability of the implant. So if you look at the left side of the image, and this implant right here that we're placing, this is a pretty long implant. This is a 13 millimeter implant. So see how much of the implant is actually engaging native bone after the extraction saw. If it's more than 4 millimeters, we'll say that this implant will probably have an adequate primary stability. On the other hand, if you look at the right side and you have a 6 millimeter implant, which is a pretty short implant, and most of the implant is actually not engaging native bone, most of the implant is in the sinus, so we'll say that in these cases where we have less than 4 millimeters of native bone engagement, we have what we call questionable primary stability. So in such cases, it's always better to wait and then place the implant in a second stage surgery after we do the sinus lift. Dimension number 4 is relationship to the adjacent teeth, implants, wax up, and AP spread. Previously, we discussed dimension number 1, buccolingual, dimension number 2, mesiodistal, dimension number 3, apical-occlusal. Let's try to apply the 3 dimensions of treatment plan on the image that we have right here in front of us, and then we'll talk about dimension number 4. So on the left side, you'll find that we have 2.2 millimeters of bone on the buccal side of the implant. We have dimension number 2, we have 3 millimeters between the implants, and we have 1.5 millimeters between the implant and the adjacent tooth. So basically, we applied all the dimensions of treatment planning that we discussed earlier. But how does this implant look like prosthetically speaking? So if we look at the implant, which is this implant in front of us right now, what we'll find is that the implant is emerging way too buccal. It's emerging through the buccal side of the wax up that we have, which means that this is not an ideal placement of our implant. So the reason why we have dimension number 4 is because we want to remind you that when we're placing our implants, we're not only placing the implants in bone, because we can place the implants in perfect bone. On the other hand, the prosthetic position might not be ideal, so we need to balance between all the 5 dimensions of treatment planning, and that's why we have dimension number 4. So dimension number 4 is the relationship to the adjacent teeth, relationship to the adjacent implants, relationship to wax up and AP spread, and in this case you can see that the implant is emerging way too buccal in the wax up and actually buccal to the adjacent teeth. So what we need to consider is, let's talk about the adjacent implants and the relationship of the adjacent implants. If I'm planning 2 implants, how much is the angle difference between the implants? Are the implants parallel or are they not? The angle between the implants determines the type of abutments that will be used for the restoration. The minimal angle that we have between the implants, and the more parallel the implants are, the easier they are to restore. We could just use tie bases, we can use straight stuck abutments, and the prosthetic procedure is really easy to do. On the other hand, we have a divergent implants. The implants are not really parallel. Those become a lot more difficult to restore. The reason why is because we'll need to use multi-unit abutments or custom-made abutments, which make the prosthetic procedure a lot more difficult and cost even more to restore the cases. And that could have been easily avoided by planning the 2 implants to be nice and straight. Very good. So we talked about all the dimensions of treatment planning. We talked about dimension number 1, dimension number 2, dimension 3, dimension 4, and now let's talk about dimension number 5. Dimension number 5 is bone density and loading. The reason why I have this dimension is because most softwares out there don't really give us a lot of information about the bone density of the site that we're going to be placing the implants in, and the probability of us to do immediate loading in these sites. All the different softwares out there will give us dimension number 1, 2, 3, 4, but very few softwares, or basically the only software that I know will do this is Artogate. So let's talk about dimension number 4 a little bit. Why do we need to know the bone density in the future implant site? Before we answer this question, let's just lay out some facts. Fact number 1. We have higher failure rates for implants placed in the posterior maxilla rather than the mandible. This is a fact, and the reason why is because the bone density does play a role in the implant's primary stability and subsequent osseointegration. If I place the implant with higher primary stability, the odds of this implant osseointegrating are actually higher. So this is basically a fact. Fact number two is implant's primary stability is not a one-sided coin. What do I mean by this? It means for me to get good primary stability, I have to look at two things, not only one thing. So the first thing is implant design. So we always advise you to use a good implant design. But as we said, that's not the only thing. We need to consider two things. Number two that we need to consider is actually instrumentation. How much drilling are you doing? Because remember, even if you have a great implant design, if you do a lot of drilling and the osteotomy is wider than the implant, will not get good primary stability. So this is also one of the things that we have to bear in mind. So the two factors when it comes to implant stability are actually implant design and instrumentation. And that leads me to talk about customizing the drilling protocol. What do I mean by customizing the drilling protocol? By that I mean for each patient we have a different drilling protocol that we need to follow. So let me just read this out loud. Drilling protocols can be customized after the assessment of the bone density in the future implant site. The reason why we do this is because we want to obtain higher primary stability to avoid over-instrumentation and subsequent loss of implant primary stability. Well, that's a lot of talk. What do we really mean by this? What we mean by this is we need to know what the bone density in the future implant site is. Based on knowing the bone density, we'll choose exactly how many drills we're going to be using. When we choose the amount of drills we're going to be using, we'll get good primary stability. Well, very good. So how can digital help us assess the bone density in the future implant site? And that's one of the main points that we want to talk about when it comes to ArtoGate software. So in ArtoGate software, we have this function that is called the digital eye function. And it's a really nice visual aid. So briefly, what digital eye does is that it allows us to basically move images that are gray images, like the ones you can see on the left side, and it allows us to give color to the image based on the density or the grayscale of the image that we have in front of us. So if you look at the image on the right side, this is the image that we have with digital eye. If you look at the anterior mandible and the anterior maxilla, you'll find that this is hard density bone because it's yellow color. So basically this yellow color is translated in the density scale to hard bone. The more we go towards the back, you'll find that the predominant color is actually blue. So if we translate the blue color in the density scale, you'll find that this is actually medium density bone. And if you go more towards the back, you'll find that this is really soft bone, and because the color is actually red in this case. So basically, this is something that you could not have imagined by looking at a normal grayscale image like the one that we have on the left side. And that's why we say the digital eye is a simple, logical visual aid that gives you good information about the density of bone in future implant sites using color information. And this is basically how that looks like. So D1 bone is mostly yellow, as we previously mentioned, and D4 bone is mostly red, as you can see here, and this is how D2 and this is how D3 looks like. Very good. So based on the bone density analysis that we do with digital eye, we can now customize the drilling protocols. So if I place a 4mm implant in D1 bone, which is very dense bone, my final drill makes sense that this drill is actually 3.8. So for a 4mm implant in dense bone, our final drill is only 0.2 millimeters smaller than the final drill width, or than the final implant width, which makes a lot of sense. So what if we place the same size implant, 4mm implant in D4 bone? What you will find is that we removed one drill, and now the final drill is going to be 3.3. The reason why is because for me to get good primary stability in D4 bone, I need to skip one drill and I need to adjust my osteotomy and drill with the final 3.3mm drill. And now with ArtoGate, this is done automatically through what we call the ArtoGate 3D diagnostic report. So you'll find information about the future implant site, the size of the implant, the density of bone, and how many drills are actually recommended to use. In this site, this is a D3 bone, and the recommendation for a 4mm implant is that the final drill is going to be 3.3. Now let's go back to our main point, efficiency. We talked about efficiency in planning and how we use R2Gate for this, and how we plan based on the 5 dimensions of treatment planning. Now let's talk about efficiency in executing. How can we actually execute and apply what we planned for? And that's why I have an image of a surgical guide. I know a lot of dentists out there are not doing guided surgery still. Most of their cases are actually being done freehand. So a case like this, where we have 10mm in the thinnest portion of the bone, in this case, it's okay to not use a surgical guide because the surgery is going to be easy. So do we need to use a surgical guide for this case? Well, basically no. But let me tell you why I've changed my mind completely and now I'm doing everything guided. So even for cases like this case on the left side, which is a very easy case, it looks like we have a good soft tissue situation. The amount of bone that we have in the CBCT is actually more than excellent. But what I want to tell you is, with my surgeries, I always go in with what we call a prefabricated crown. So I have a crown that is ready-made before the surgery. And I need to remind you that this crown only fits in one position only. So the reason why I use a surgical guide is because the surgical guide will help me place the implant in the only position where this prosthetic will fit. So what I'm doing is I'm not really doing guided surgery, I'm more doing guided prosthetics. And there's a big difference between guided surgery and guided prosthetics. We're way beyond guided surgery and we're moving more towards guided prosthetics now. And there's a big difference between the two. And that leads me to talk about the rise of the one-day implants concept. What is one-day implants? Essentially immediate loading. And there's so many different people in the world that are applying concepts similar to one-day implants concept. We call it different names: same-day teeth, new teeth in one day, smile in a day, all different names, but it's essentially the same thing. Which of these protocols is the best protocol? That's a very good question. Well, to answer this question, let me tell you that ideally the process of one-day implants should be like this. It's a process where we place and restore the implants in the same day utilizing digital protocols. So what we need to do is we need to place and restore the implant in the same day. All planning and manufacturing of the prosthesis should be done before and not after the surgery to minimize the chair time, and we need to do this process with very careful treatment planning and consideration to all aspects of treatment. Well, very good. So let's talk about the R2Gate one-day implants protocol. The great thing about R2Gate is that now when you're doing the treatment planning, you'll be able to export multiple different types of abutments from the software along with the model of the patient. And that allows you to choose what type of final restoration or what type of temporary restoration you'd like to do for the patient. So for instance, you can export a scan abutment, you can export a stock abutment, you can export a multi-unit abutment, and these are all methods that would allow us to actually use and develop a prefabricated prosthetic. So now, instead of doing a chairside restoration and opting for a prefabricated restoration instead. So I'm now doing everything prefabricated because R2Gate actually allows me to do that. But now the question is immediate loading safe to begin with? And that's a really important question. We talk a lot about different types of prosthesis and what would be better, prefabricated or chairside. But the question is immediate loading safe to begin with? And that's a really important question. Well, the answer is yes, if done properly. So what do we mean by if done properly? That's a really important question to ask. Well, in order for us to know if the immediate loading procedure that we're doing is actually a safe procedure, we need to have criteria. So the criteria that we have is insertion torque and ISQ. So let's talk about this in a lot of detail. So we have three clinical scenarios that we might face: either a single restoration, multiple restorations, which is basically a bridge, or a full arch restoration. So if you look at the right side, you'll find that in order for us to place a single restoration and to load it immediately, if we get 45 Newton centimeter and 75 ISQ, it is considered safe to load the implant. If we get 40 Newton centimeter and 70 ISQ, and we have a bridge, and this bridge is splinted, we could place and load the bridge in the same day. If we have a full arch case and we get 30 Newton centimeter when we're placing the implants, and we get 65 ISQ, and we have what we call a full arch restoration with cross arch splinting, it is considered safe to load this restoration. So basically you find that the more implants we have and the more splinted they are, the numbers actually go down. And that's because we have the splinting phenomena. And with full arch restoration, we have what we call cross arch splinting. So we have implants on either side of the arch that are actually supporting each other. With this in mind, let's show the first case with Artogate. This is a case where the patient came missing or had a broken lateral incisor, and she wanted to restore that lateral incisor as soon as possible. So what we had designed for her is we wanted to do immediate loading for her, and we wanted to do a socket shield procedure. So we wanted to do the socket shield procedure, if possible, guided. And that's what we wanted to do in this case. So with Artogate software, we planned the implants to see that we don't have a really thick plate of bone. So it would be ideal to actually do a socket shield procedure here. We placed the 3.5 by 13 millimeter implant in this case. This is how the patient started out. So we always start with using Gates Glidden drill to make sure that our canal is nice and patent. We use what we call the Apex guide, which is a guide that I've developed with Artogate, which actually allows us to hit the apex of the root using the surgical guide and using the root membrane kit from Megagen. After we hit the apex, what we do is we use the initial shaper drill. The reason why we use it is to make that horizontal cut that we need to be able to separate the root into a buccal and a lingual fragment. After we do this, we can do the extraction. We extracted the palatal portion of the guide, of the root. We've done debridement with laser inside the socket, and then we're able to use a second guide. In this case, the second guide is actually used to do the drilling for the implant and the implant placement. We placed the implants, we got 78 ISQ, which means that we got higher than 75, which means that I could actually load my restoration in the same day. This is a 3D printed crown, and this is how a 1 week follow-up looks like for this patient. So basically we see now how with Artogate we could do immediate loading procedures, and even procedures like guided socket shield could be done. So do we always get the numbers that we need for immediate loading? Do we always get 75 and 45 Newton centimeter? Well, the answer is not really. So this is a patient that was missing also 2 lateral incisors, congenitally missing. I wanted to place implants. I wanted to hopefully restore those in the same day. So what we've done for this patient was we've gathered all the information, CBCT, a model, and the picture of the patient. And in digital oral design, which is a module inside Artogate software, we're able to join all the information together, gather all the information together, and we're able to do a smile design for our patient in the software. So the reason why we do this is because we want to make sure that even the temporary restoration that we do for our patient is actually nice and aesthetic. Right after we've done this, we're able to export the smile design out of the software, and we're even able to use the smile design to place and to plan our implants. And this is everything that is done prefabricated for our patient. You see here the crown of the patient and also the surgical guide. This is how the situation looks like intraorally. Laid a small flap. We've done the drilling through the guide. We even used osseodensification in this case. We placed the implant through the surgical guide, and we got only 25 Newton centimeter. We measured ISQ also for this case, and we got only 68 ISQ. So if we get only 25 Newton centimeter and only 68 ISQ, can we load this case immediately or not? So let's go back to the criteria. We said for single restorations, we need 45 Newton centimeter and we need 75 ISQ. We only got 25 Newton centimeter and 68 ISQ. So I think in this case, it's not really safe to do immediate loading for the patient. So what we've done for this case is that we sutured the patient up and we let the patient go because we know that this would be the right clinical decision in this case is not to load the patient. Now, let's talk about efficiency in follow-up and how could we also be efficient after we finish our treatments. So let's talk a little bit more about ICU and how can we schedule the follow-up for the patients scientifically and efficiently. So as we mentioned previously, if we get high stability, like above 70, from 70 to 75, if we have a single case, we could do immediate loading as we previously mentioned. Or if I have a posterior crown, I could do one stage, meaning that I can place the healing abutment on top of the implant immediately. If I get 65 to 70, if I have a partial case, I could do immediate loading. If I have a single restoration, I could do 1 or 2 stage and I could do what we call early loading. So basically, I could place the healing abutment on top of the implant and I could load early. I could load from 4 to 6 weeks. If I get 60 to 65 ISQ and I have a full arch case, I could do immediate loading. If I have a single implant, I need to do 2 stage, which means I need to bury the implant and I need to place the healing abutment later on, not immediately, because the amount of stability that we get doesn't allow us to put the healing abutment on top of the implant. And in this case, we do what we call traditional loading, which means that you wait for about 3 months, not 4 to 6 weeks as we used to do before. If I get less than 60, this is very low ISQ, very low stability of the implant. It means that this implant is at risk. You have to monitor the ISQ of this implant, which means you have to bury the implant and wait even longer than traditional loading. So this is basically how we could do our follow-up with the patients, and this is how I know exactly when to call the patient back for a recall impression. So this basically allows me to not wait for too long and to deliver the crowns for the patient faster and safer. And now I'll end my lecture with a question. How many times do we screw things on and off the implant from placement until restoring it? I know sometimes we'll place a cover screw and then we remove the cover screw and we place a healing abutment. We remove the healing abutment to put the impression copings, and then we remove the impression copings so towards the end we could actually place the final abutment. Well, if we do a 1-stage protocol, we do 7 times, and if we do 2 stage, we do remove things on and off the implant 9 times. Well, does that really affect the biology around the implant? Absolutely. So we have a study that was done by Abramson and Lindy, and it showed that every time we remove the healing abutment off the implant, that causes a disturbance in the attachment that happens between the abutment and the soft tissue. And if we do that more than once, we actually start to lose bone towards the end, and this is an experimental study that was done in dogs. So is there any way we could reduce the amount of changing and removing things on and off the implant? Well, yes. So let's see. We came up with a solution that is called the healing abutment, that is a scannable healing abutment. So this abutment is basically a mix between a normal healing abutment and also a scan abutment. So it's composed of 2 parts. The bottom part is a healing abutment and the top part is a cap that acts as a scan abutment. So let's see how we use that. This is a case that I got from my good friend Dr. Marcus Ingelshout that shows how we use this scannable healing abutment. So this is a patient that we got. We've done a panoram. We placed the implant for the patient. So it's a very easy case to do the surgery on. But instead of placing a normal healing abutment, we placed the scannable healing abutment and we sutured the implant up. We made sure that we took an x-ray and we made sure that the scannable healing abutment was fully seated on our implant. Now we wait for a couple of months, and this is how the patient comes back. Rather than removing the healing abutment and placing a scan body, then removing the scan body and placing the healing abutment again. The great thing about the scan healing abutment is that you don't actually have to remove it. All we have to do is just clip a cap on top of the scan healing abutment, and then it becomes a scannable abutment, as you can see here. This is how we scanned the abutment in place. And we scan the upper, we scan the lower, and this is basically all the scans we need in order for us to proceed and send the information to the lab. We send the information to the lab, and the lab designed a screw-retained restoration for us. This is basically how that looks like. And again, it looks like the amount of bone that was preserved around the neck of the implant actually tells us how important it is to reduce the amount of screwing things on and off the implant. My take-home message is this: using digital planning and guided surgery is the right way to free ourselves from complications and anxiety. Remember, to prepare is better than to repair. Prefabricated prosthetics will help reduce chair time and increase efficiency. Using digital devices like ISQ will help us know the right time to schedule patients back for recalls and impression appointments. Smart digital tools like scan healing abutment can help us promote biology and reduce the scanning and chair time. With this in mind, this is my lecture, Maximizing Efficiency Through Digital Planning with R2Gate. This was Dr. Sam Omar, and again, I would like to thank the EDAD for the invitation. I would like to thank you all for listening to my lecture here today. Thank you very much, and see you next time.